actually saving money. So every congressman, as far as I could tell, wanted to include it in the ACA because that let them spend money on something else. So I think those two things helped. And then probably the most important thing was the energy that started to emerge in the places that were doing this early, whether it's Advocate, Tucson, the excitement of the places that stepped forward, Massachusetts, that said, we can make this happen. Because in complex adaptive systems, all it takes is one positive deviant and everybody else starts to follow. So those would be the three things I'd highlight.
Yeah, I agree with that. I think from a legislative side, there's something about having a negative number in front of a proposal that doesn't cut someone's payment rates that is a good generator of bipartisan support. But that happened because of the
it sounded like a very attractive unicorn, is what you're saying. People wanted to believe in it, whether it was real.
But it happened because of the early unicorns. Elliot and I started working on this after I left CMS, and while at CMS we had implemented the physician group practice demonstration. I'm not sure that's a better name than ACOs, and that one's come under a bit of criticism lately for it didn't definitively save huge amounts of money. But if you look back at it, all 10 of those organizations substantially improved population health care and quality of care and outcomes. No question about that. 9 out of 10 achieved significant savings. 5 out of 10 got to the 2% threshold, and if we could get half of our healthcare organizations to get 2% off trend per year, that would be enough to really change the red outlook on that chart. There's certainly some issues around as you switch payment systems. It's something that Medicare always sees happen. As you switch payment systems where payments depend more on diagnoses and quality of care, you get more comprehensive reporting of it, and that's typically a one-time shift. So, I came away from this, and certainly the 10 organizations that were participating in this came away from it thinking this was a good step. Not enough, but a good first step. That combined with the activities then going on in the private sector, I think made a big difference. And it's important to remember that the notion behind ACOs from focusing on better quality and lower costs isn't new. We've had organizations around the country that have done that in different places, California and elsewhere, for years. What I think was new this time around is that fiscal pressure and the opportunities of ACOs potentially to do something about it because of its early evidence. Second, the fact that this round of healthcare reform is much more physician and clinician-led than, say, the 1990s effort around health plans, leading efforts often engaging physicians, but ACOs and these provider-based reforms have much more clinician involvement. I think that helps with both effectiveness and public acceptability. And then finally, we're at a different stage in terms of our information capabilities and measurement capabilities and technological capabilities around
but Elliot, you spoke a bit more about it. This issue that depending on whether you're in the Medicare Shared Savings Program where you refer to it as beneficiary attribution or you're somewhere else and you refer to it as how do I know my patients are going to stick with me and not go off and use other providers. You used the phrase, I think it was Stu Gutterman's, you said the best fence is a good pasture. I was involved in a conversation the other day with some of the pioneer ACO folks, and we were couching it as, what would it take to have all of your attributed population or your members or whatever we're going to call them a year from now or 2 years from now willingly put on a T-shirt that you gave them that said, I'm a proud member of XYZ ACO. With that, what would it take? And is it, now you've talked about some of the possibilities around benefits, structuring flexibility of benefit structure to really entice people in. But really, what would it take to get people to really feel a sense of investment and belonging and want to be with an organization that is going to be the modern ACO?
I don't think it's going to be about, it's going to cost me more to go somewhere else, so I'm forced kind of financially to stay here. It's going to be about, this place is providing me extraordinary care, surprisingly good care. When I call up, I can get in to see my doc the same day. My doctor, or his team or her team, and I feel well cared for. After hours, I know I'm getting great care. And if you look at some of the Berkeley's pilot sites that are here, they're actually figuring out magnets that you put on the fridge to say, here's how you get help at any time. So I think it's going to be about the experience of care that patients get. It says, why would I go anywhere else when here I can, I'm getting absolutely spectacular care. I'm being helped to make wise choices. Dartmouth makes a big deal about informed patient choice. The problem of wrong side surgery is nothing compared to the problem of wrong patient surgery, where patients, are chosen, are told to get a procedure that if well informed they wouldn't have gotten. So I think it's when patients feel that they're getting extraordinary care, great access, and wonderful information that helps them and their family members make wise choices, that they'll go, I want that t-shirt.
You agree?
I agree with Elliot, and I think this is an area where just another version of alignment is if we can have physicians, other healthcare professionals, and patients clearly working in the same direction, as opposed to the way it's been in the past, where there's understandably been a lot of patient distrust that any effort to save money is coming at my expense or the expense of my loved one. Overcoming that is the most important step in a successful ACO, and you need the kind of financial alignment that an ACO provides to make that happen.
Another kind of soft metric that we discussed the other day with the Pioneer ACOs is, what would it take so that every member of your organization willingly put on a t-shirt that says, finally, I remember why I got into healthcare in the first place?
What a wonderful what a wonderful vision. What would it take? The Tucson ACO, the sense that the system is working for the physicians to help them do a much better job of taking care of their patients, and for the nurses and clinical teams. Pal Evans, who's came back from retirement to help launch that, is quoted in one of our reports. This is the first time since 1974, when I came to medicine, that I think it's coming together for the patients. And so I think it's going to be about not someone, an organization with which I'm familiar well is saving money by telling every department to cut spending by 6% and lay off 6% of their staff. I don't think that's the way we're going to have people in healthcare feeling great. I think it's about great frontline support that makes you say, shoot, this is why I came to this work.
I agree with that. That's exactly right.
All right, well, let's open it up to conversation among all of us, and comments, questions, short speeches masquerading as questions, whatever. And
there's some microphones.
We have some microphones.
The first volunteer for a speech.
Let's see, we got one right over here. If you can pass the mic, maybe just pass. There we go.
Thanks, Peter.
Thank you. Steve Blackschaffer, College of American Pathologists, and also Partners Healthcare System. And Mark made a really interesting comment in his presentation, which had everything in it, which aligns very well with one of the things I'm very interested in. He observed that the patient-centered medical home and bundled care are sort of separate entities conceptually, but in fact we may be making too much of that distinction. As we've been trying to actually implement care that's aimed at our most vulnerable populations, we discover those two things are sort of blending together like mercury drops. They really need specialty care as part of their medical home. Could you comment on whether those concepts as distinct entities have perhaps become counterproductive, as opposed to really needing to come up with sort of a meta-concept where they really blend together and provide comprehensive care?
Or are they just different tools that ought to go in the same toolbox? And we need to think conceptually about it that way.
I think as one, if you look at many of the models that are out there, as they start to think about redesigning care to provide the best care possible for distinct clinical populations as opposed to patients one by one, you start to think, how do you provide the best care possible for diabetics? And that involves the endocrinologists just as much as the primary care physicians and nurse educators. Brent James' work at Intermountain Healthcare, or the Project ECHO work of Dr. Arroyo in New Mexico, a hepatologist who's taking care of, as far as I can tell, the whole state of New Mexico and their hepatitis C problems. So absolutely, the notion that the medical home can thrive without a medical neighborhood, it's not going to work. But I think that the challenge is to get everybody has to figure out how to get on this particular transition in a way that fits where they live today. Neil Kalman, who's a member of our ACO Learning Network in the Bronx, gave a term that I found really helpful in thinking about this, which is that we tend to think of healthcare as redesign, designing a new house. We're going to have this spectacular 3-bedroom building that, greenfield conception of how you do this. But in fact, everybody's living in a house right now that has a chimney in one place, a bathroom in another, the kitchen's in the wrong place, and it's a renovation everywhere. Healthcare, even at the practice level, is fundamentally local. So if we can figure out ways that primary care practices can get on and start to do relevant work, that specialists can start to align in and outside the hospital and maybe with medical homes, I think the three pieces of that puzzle can start to fit together, and in the long run, of course, they have to.
Okay, let's take another question.
Yeah, my name is Pete Paisley. I'm from St. Barnabas in New Jersey. I just came out of private practice for about 12 years and joined now hospital employed. And I'm curious what your thoughts are about why fee-for-service has been so dismissed. I mean, it seems to me it was the model that really had been in this country for many years. And I think there's some positives to fee-for-service. I think it incentivizes doctors to work harder. And I just was curious. It seems to me the bigger issue is specialists, the specialists in their connection with the technology. It strikes me that that's maybe even a bigger problem. And I mean, at the end of the day, aren't we just going to have to pay specialists less for what they do and pay primary care more?
Yeah.
Good luck with that question. How many specialists raise your hands, please?
Create a more even balance. One of the things about, picking up on Elliot's last answer, and this is something that we're going to talk about in those sessions over the next couple of days that deal with implementing payment reforms, one of the things about ACOs is that they certainly have not moved fully away from fee-for-service. There are pieces where they've definitely moved away, and if I was going to oversimplify a bit, I'd say that one of the major pieces is in primary care payments, where fee-for-service actually doesn't seem to work really well, because many of the things that primary care doctors do today that are very efficient in caring for patients, like answering emails and helping with coordination, follow-up, working with nurse practitioners and other practice extenders, are just not reimbursed under fee-for-service at all. And it's not a question of the rates being too low relative to specialists. They're just not paid for at all. And that doesn't lead to, that really gets in the way of efficient care and really contributes to those frustrations that Elliot and Susan were talking about earlier. But in many ACOs, they are still relying on fee-for-service for certain types of specialty services, for more individualized care where you got to customize more. And I personally think that we haven't got the definitive answer to what the right combination of payment systems really are. I do think, as I talked about earlier, that some movements in the direction of medical homes and bundled payments and ACOs paying on a more at least partially capitated basis is probably the right thing. But there may be other specialties or services where that doesn't fit very well. What I definitely think we need to do, though, is get out of this mode of looking at the kinds of silos that fee-for-service tends to promote. So that's been not just a problem for ACOs, but a problem for physician payment generally. The fight we have every year over the SGR turns into a circular firing squad among different physician groups, because they view the pie of physician payments as being something they just have to divide up with the relative value units. And in fact, the right way to think about it is that pie of physician payments is 13% of all Medicare spending, and the decisions that physicians make influence 80% of the total. So you can do a lot more by specialists and primary care physicians finding ways to work together to augment and partially move away from fee-for-service to capture some of those overall savings through better care coordinations, through making referrals work more efficiently, through, as Elliot was saying, getting the right patients, the right specialist for the right services